Okay, we're getting everything set up here. Okay, looking good. Okay, let's pause that. Welcome, everyone. We are going to dive into a pretty important topic. As a healthcare industry, we are doing a great disservice for the acute postpartum population. We are missing a vital opportunity to prevent injury and death if we continue to overlook providing rehab services for this much deserving population and right to equitable access to care. I'm Laura Rowan, pelvic health occupational therapist, educator, mentor, and advocate. And I am thrilled to have Jessica Hammond and Rebecca Seagraves with me today. Welcome.
Thank
We are
you.
going to be, the reason we are all here today is because we are going to be live on stage in Orlando for the American Occupational Therapy Association conference coming up in 2 weeks. So March 21st, we are going to be talking about this very important topic that these two thought leaders and change makers have been really paving the way for this important change. And so let me introduce Jessica. So Jessica is an occupational therapist. She started a postpartum program in her hospital. Jessica, welcome. Can you tell us a little bit about what your hospital is, where you're at?
Yeah, sure. I'm located in Pittsburgh. I'm in St. Clair Health. It's St. Clair, previously St. Clair Hospital. We're in the South Hills of Pittsburgh, so we're not right downtown. We're a nice, easy commute for a local community, so people don't have to travel through the bridges and tunnels to get to the city. So we service all of the South Hills here.
Okay. And Rebecca is a doctor of physical therapy joining our crew. And we're going to talk about why that is. And Rebecca, welcome. Thank you for your time and energy. Tell us where you're coming from.
Yeah, sure. I live in Colorado Springs now, but my journey kind of really began at Texas Children's Hospital. It was a level 4 perinatal trauma center. And for people who don't know, the highest, most complex births, NICU, maternal health. And I started a program with a team there. And within about 6 months, every person was able to get automatic orders after C-section, and moved to Colorado, and we did it again in the largest birthing hospital in the state. And so it's kind of where my journey begins.
Okay. And so a few brief talking points that we're going to cover today. We're going to highlight the importance and the risk that we take by not serving this population, the why and how OTs are uniquely positioned to be able to help and support this population, and how to get involved. So let's dive in. Jessica, can you please share with us your why, your inspiration for getting into pelvic health, but specifically starting this program at your hospital 5 years ago before it was really being talked about?
Yeah, so after I went through pregnancy and delivery, I realized that there was this huge gap in services for people after they deliver babies because there was not much support for me. I remember when I first took a shower after I had a vaginal delivery, but after I took a shower, the next day, it was 24 hours later, I got in the shower and I just felt like lightheaded and dizzy. And I was there all by myself with the baby, and my husband was home with the dogs because we had 2 dogs at the time. And I just felt like, man, like this would be a great place for OT to be. At the time, I was working in inpatient rehab at the hospital. And I thought, every time we take someone in the shower, I'm there with them. I don't just send them in and leave them. So I thought, gosh, this is an area I think OT should be working in. Plus, the big transition into motherhood from like, having all your time to yourself to like being kind of at the beck and call of this child. It was just a big transition. It was difficult. And I thought, boy, that sounds like OT. Like, why are OTs not doing this? And I just couldn't understand why OT wasn't doing it. So I just mentioned it to my manager, and I was like, I think this is something OTs need to do. And she's like, well, you probably need some kind of training. And I'm like, well, I'm not really sure. I think we can just try to do something. But she did send me to like a pelvic floor course, because if I was going to be talking about pelvic floor things, but I think any OTs could do it. And
I think that's an important point, Jessica. Sorry to cut you off.
No, sorry.
We were going to talk about it a little bit later, but might as well dive into it. The services that you're providing and that you're seeing at this stage in the game. So we're talking about acute care within like day 6 of delivery. Mm-hmm. What you're seeing to be able to provide to help support these women and birth people, it doesn't require advanced training. It's just taking what we already have as a skill and applying it to this population.
Yeah, it's asking the same questions. It's helping people in and out of the bathroom, maybe that just recently had a vaginal delivery or just had a recent C-section. It's, giving them the tools to make them more comfortable, safer, and better able to know their own bodies a little bit as they're moving around and doing these things. It's also providing support. There's not a lot of support people there. The nurses aren't always in there when people are getting up, except for the first time. But I mean, people are just kind of like feeling it out themselves. They're not really sure how to do what they're doing. Sorry. That thing's going to beep. Yeah, so I'm seeing right now in our hospital program, we're servicing the people post cesarean section, so unplanned cesarean sections. But occasionally I do get the 4th degree tears, or I get the vacuum assisted deliveries as well. So just kind of, if there's a need, they usually will call because they know that we can really help these birthing individuals, and they see our value for sure.
Yeah. And Rebecca, can you talk to us about, you have lots of great information on, how it's common for us to just automatically go in as OTs and PTs to provide care for most other hospital stays and surgical procedures, but we're not addressing this population the same way.
Oh, yeah, absolutely. I mean, that's how I started out my career. We were seeing people after knee replacements, hip replacements. As a student, I was exposed to that population early on. And so when it came to surgery, I think within about the first 2 years, just as Jessica just said, gaps in care. And it was largely with women's health surgeries, your mastectomies, your hysterectomies, your C-sections. And so I was actually pretty fortunate. I worked in a hospital that allowed a little bit more autonomy, and Jessica can speak to this. Like acute care therapists, we talk about autonomy. We don't just have access to patients. We have to get an order. It's very rare that we can actually screen for our patients. And I worked in a hospital where we could. So we would actually get on the maternity unit and see who had a C-section that day. And we could go into their room, not into their chart, but go into their room and offer therapy services. And I promise you, about a month into really doing that, it was 2020, top of COVID. We were cutting our hours. Some of us were just staying home because there wasn't a lot of work. There weren't a lot of elective procedures at that time that we were seeing in the hospital, which were your endometriosis surgeries, your prolapse repairs, your hysterectomies. So the only population that was really keeping kind of everything going rehab-wise were people giving birth. So your cesarean section, your 3rd or greater degree vaginal tears. And so we would actually be able to screen those patients and offer our services. And that was like the most autonomy I've ever seen in acute care. I mean, think about it. Like, patients are more autonomous on where they get to go, on who gets to go into their room. And so that brief interaction that I would have with people realized for me that it was more important at that time to market to those individuals why and how we could help, right? And so before we ever got automatic orders from surgeons, we were really, really focused on those individuals on educating them and kind of empowering them to order us until it became standard of care, which took about 6 months to do. But that was really kind of my aha moment was I'm not autonomous, really, as a PT. As an OT, we hadn't gotten automatic orders for that discipline. And I started realizing the issues that were bringing women back into the hospitals, these individuals were cesarean incision infections. They were hypertension, preeclampsia, all these issues. But guess what they were doing? ADLs, trying to cook and clean. They might have been single moms. They might have been trying to navigate steps. They might have been trying to care for several children in addition to their newborn. And so to me, OT needed to be on the team first and foremost. PT could get them up. We can, walk. We can negotiate stairs. Where were we going to go? Right? To the kitchen. What were we going to do in the kitchen? We were going to meal prep. What were we going to do when we came back to the hospital? We were going to walk to the NICU and try to care for our baby while they were also healing. So to me, OT needed to be primary on this team. And that's what I've been doing since 2020 is trying to get OTs at least seeing this population while they were still in the hospital.
Awesome. And that's what drew me to you at first about this time last year, Rebecca, was you were promoting, and we're going to talk about this in a minute, you were promoting your educational offerings in a way that put OTs first. And I said, wow, who is this doctor of physical therapy putting OTs first? I mean, we all have our special sauce. We all have our role. We need to have all hands on deck to be serving this population. But it really struck me that you were speaking to OTs and the frontline vital role that we could be playing with these women. And again, I want to make sure that, so I may interchange women, mom, birth person. We want to make sure that our language is inclusive and supportive. So, okay. So Jessica, share with us the impact that you've been seeing. So as an OT, you found yourself heading this up. You felt it from a personal level, and saw the need, right? The opportunity for change. Because sometimes we just do things because we just have always done them, right? We just need a little bit of inspiration to reimagine and do better, right? And so let us know the impact that you've been seeing.
Yeah, I think the impact is pretty enormous with the people that I've seen so far. I mean, going through the years, it's just kind of just educating people about, how to get up the first time, maybe how to log roll out of bed, how to get up from a chair with comfort and not pain, educating them about services that are available to them when they leave the hospital. I've seen through the years, I've seen people with severe tailbone pain or injury. And, they're like, how am I going to make it when I get home? But we can kind of be the resource to them and give them the skills they need or the resources they need. So we have a local home health agency that does pelvic health. So if I see someone in the hospital and I think, darn, they're going to struggle when they get home, they don't have anyone with them, I'll usually refer them to someone that can come into the home and do home pelvic health to give them some guidance. But as far as impact goes, I think that we're just there to support, and people really feel that when you talk to them afterwards, months afterwards, they say, yeah, I really remember when you came in. You're the first person that asked me how I was feeling. You're the first person that assisted me or gave me advice on how I can move so it doesn't hurt. You're the first one that helped me put the abdominal binder on. So it's those skills like that connection that we can make with people, asking them about their house and who's going to be helping them when they get home, and giving them permission to ask for help. It's okay to ask for help. You don't have to do it all. You don't have to be the hero here. Take time for yourself, take time to heal yourself, and don't try to, be a champion and be the only person that ever had a C-section and went home and cleaned their house from top to bottom. Like, you don't have to do that, right? So I think giving them permission to rest and recover is helpful.
Yeah, and often we are the only ones that have the time to be that active listener and support and guide for these people. And I know on my end, because I'm not in the hospital setting, I'm in private practice. So I'm trying to help reach as many women when they're pregnant so they can self-advocate for themselves. They can be asking these questions, asking for services, and be prepared with this information. However, that I can only reach the people who find me beforehand. So that's why it's so important when we talk about equitable access. We need to get these programs established and get these services offered, right? They shouldn't have to be educating themselves and advocating for themselves. We need to do better to be able to provide it for them, right? Okay.
Yeah, especially in the hospital, right? Where they're choosing. They've made the choice to give birth in the hospital. 98% of births occur where? In the hospital, at least in the United States, right? And so to me, it's like if I'm going to the hospital, I have this idea, I have this birth plan for the delivery I want, the experience I want, and it doesn't go to plan, and I end up having a major surgery, that's bare minimum. That's customer service. That's the client experience. That's the patient journey. That terminology, I think honestly has been inspired in me by Jerry Durham. He's the founder and CEO of the Client Experience Company, and I just love that because it humbled me. Here I am, a doctor, board certified women's health clinical specialist, did a residency at Duke, and I'm humbled to say that patients have the autonomy once they have the information to choose who their health care provider is. And that happened in 2021 with a woman who actually was spending her high risk pregnancy stay in the hospital, and she asked for therapy. She initiated the referral. And so to me, the more people I've interacted with has been this awakening moment like, wait a second, we give them the education, they initiate the referral. I don't need to go to the doctor. Doctor has to still put in the order, but who initiated that referral was the autonomous patient, right?
Yes. And Rebecca, can you speak to, we've got a little bit of your why and your inspiration and what you are doing. Can you talk to us a little bit about how you took that a step further and are educating and supporting these programs? Because even though we may not need to specialize in pelvic health to be doing this work, it's important to have support to be able to be successful in starting these programs and achieving max outcomes.
Yeah, I mean, I think for me, I wanted to go after the professionals who are already there, right? We know that the United States, of the income, driven countries of the world, the top developed nations of the world, has the maternal death out rate that far exceeds the other high income countries. We know that the U.S. has the worst maternal health outcomes. And so for me, where I was really focused on was that time period where those maternal outcomes were the worst. And that was the first 6 weeks, right? First 6 weeks, we were losing more moms during that time period. First 6 weeks speaks what? Acute care. It speaks that first 30 to 42 days after delivery where moms could be readmitted to the hospital, or they could be at home and they could have an event that brought them back to the ED, right? And so for me, we needed to really focus on the providers who were already there because, Laura, just like you said, as an outpatient therapist, you don't work within that acute care period, right? And so a lot of our pelvic health therapists, myself included, were waiting 6 or more weeks. And that's like an archaic model of care, but we were waiting 6 or more weeks where we would not do that for any population, not after knee replacement, not after hip replacement, not after shoulder surgery, nothing. But after 6 weeks after a major C-section, we were waiting to offer rehab services to help and aid recovery. And so for me, I started to zone in on my colleagues in acute care to basically fill in the gaps in what they knew. They knew how to take vital signs and actually detect if someone was going to have problems when they returned at home, to do all of those kind of like more instrumental activities of daily living. They could actually detect that faster than a nurse who was typically, and Jessica, you could speak to this, nursing care typically assesses vital signs at rest. They're not actually seeing the patient in action in their home environment, so to speak, right? And so for me, giving the acute care therapist the knowledge of more of the pregnancy, birth, postpartum period education to me was most important because they could do the groundwork. They can do the heavy lifting to detect issues before they actually arose in this population. So I started providing more education to them, and then I started to go after more of the hospitals I didn't work for. And that was truly powerful to start a program in a hospital that I didn't work at before. And so we've been able to really expand the services and access to OPT in several hospitals throughout the country. And on my site, we're keeping a list of those hospitals.
And I just want to say thank you, Rebecca, for fighting through what you have going on with your throat. I'm sorry. You just have important things to say, so I can't stop asking. Jessica, do you want to speak a little bit on cultural biases and the mental health gap?
Yeah, so I feel like with this population, because sometimes people are ashamed to have mental health issues after childbirth, that they're often not bringing these issues up to their provider. Maybe the providers aren't asking the right questions. Maybe they're missing the fact that lots of people are experiencing these mental health type issues. And there is, kind of a sense of shame for these people who think that they're supposed to, have their baby and be fine, be happy. And that it's kind of a cultural norm in that people think that the pregnant person should deliver and be fine, but really that's not always the case. So there is that tendency to prioritize the needs of the baby over the mother, and that kind of can cause issues going forward because that mother needs to be well, their mental health needs to be well for that baby to thrive. And the mother also needs to be taken care of, and that's something that we often as a society forget about or turn our back to. So we need to make sure that we're addressing that and making sure that we are seeing that in the hospital and getting these people the services that they need, picking up on that, picking up on that anxiety or picking up on that that depression or fear right off the bat, or just saying, hey, it's not unusual for you to maybe feel these things. So here's some resources if you do, and don't be afraid to reach out for help because it is very common that these things happen. So just giving them that permission and giving them that kind of support in that way. And I think OTs are great at kind of bridging that gap between the mental health and the physical health. That there's also shame and some embarrassment associated with conditions such as pelvic organ prolapse. And I think it's important for people to be just assured that, hey, if you're continuing to have this problem after birth, you can seek help and you don't have to wait till that six-week visit. Just call your provider and get some services started. You don't have to wait till 6 weeks. And I think giving them permission to ask for help before that 6-week appointment is also one of the things I really push for when I'm in the hospital, because I don't want them to feel like they have to wait. They have to tough it out and do it all on their own until 6 weeks, because there's so much we can do, whether it be from a home health or a outpatient standpoint in those first 6 weeks.
Yeah. And especially, OTs are so uniquely positioned to help support that mental health. We get that training in our curriculum, and the mental health system is so strained as it is. We need to be able to provide our services and step in where we can. Okay. Rebecca, do you have anything else that you want to add on autonomy or patient advocacy? I feel like.
Yeah, I mean, honestly, I just, for kind of the audience that will be viewing this later, just to understand why I'm coming to AOTA, this year. I think it's just humbling to really be able to talk to an audience as the PT, knowing full well that there's not a lot of people who understand what you do. I mean, occupational therapy, I'm not going back to work. I just had a baby. Like, I know you guys get that all the time. And to me, it's like I, as a PT, get to recognize that occupational is literally everything that we're doing that is just requiring our energy, right? That's how I understand it, and that's how I can communicate it with the public. And to me, the next phase of my career is really going to be zoning in on that communication to the public so that they can advocate for themselves. I know I'm not an autonomous provider. I am chained, ball and chained, linked to the insurance care system, right? The most autonomous providers, I really think, are going to be those that are accessible and that the patients are able to access when they need them, whether they're in the hospital, whether they're at home. And we're not going to have providers in the future that are saying, well, my hospital doesn't offer this program, so I can't go into the room. Like, that's not an autonomous provider for me. Even if they call themselves a doctor of physical therapy, even if they call themselves a doctor of occupational therapy, that's not autonomy. You're not autonomous. So to me, the future of healthcare is providing the patient with access that they drive. They're in the driver's seat. And that has to come through communication and education and really zoning in on, well, how can they understand occupational therapy in the best and most simplest way possible, is understanding that their activities of daily living requires their energy. If they're a mom, stay-at-home mom who has great access to maternity leave, they're still working. That doesn't mean that that person is not working any less than the person who goes to work and gets paid for it. They're still working. And so I say we need to reach everyone, and that's going to be collaboration directly with our patients, and they have to understand our language. They have to understand this conversation. If I'm going to do anything, it's to make what we're talking about accessible intellectually to the public. And that's going to be the next phase of my career, and why I'm going to every conference trying to get us to use language that's patient friendly, that people who look like me can understand, because we have the worst outcomes in this country.
Yes. And, going back to, so when I got involved 16 years ago with pelvic health, I was taken in by PTs. I say I was raised by PTs because that's who was doing this work. And, trying to advocate as an OT, I was outwardly advocating, and I realized I needed to take it home. So we needed to understand it as our own profession. And now we have really grounded our roots and really are growing and stepping up to serve this field, and cultivating that collaboration culture is so important, because not only there's still work to be done to be able to reach more people. If we start serving all of these people who have needs, we have a capacity issue. We already have a capacity issue, and we're still not meeting everyone's demands. So we need all hands on deck, and we need to be working together just like we do, and just like we serve all other populations.
Totally agree.
Yeah. So now what can we do, right? So I'm going to, let me get over here. We're going to talk a little bit about advocacy. So one, we've already talked about how you can actively listen, hold space, ask the questions, start the conversations. We already know who can get involved and who can start to be these change leaders. We also know that how to start programs, and we've got people to support us start programs, right? So my call to action is for, if this inspires you to get involved in whichever capacity makes sense to you. I also want to bring your awareness to a federal bill, HR 2480, where it is the Optimizing Postpartum Outcomes Act, and it's basically doing what we're asking for. It is asking to provide pelvic health services to this population. However, as it's currently written, occupational therapists are left out of it. And I strongly believe that we can get involved and we can get this corrected so we are inclusive. So occupational therapy and physical therapy services are supported. I have, let me get back up here. If you are an AOTA member, there is, I'm going to put it here, a website that you can go in, and aota.org/take action. And you can pop on there, you find the act or the bill that you are looking to write in about, put in your location, it will pop up your representatives, and there is a letter that we have already written for you. And you can just go in and kind of personalize it, change it however you see fit, and send it in, because your voice matters. And that's what we need. We need people to start talking about this, to really start stepping up to the plate. Okay. Does anybody else have any parting words they want to share?
I said we got to get Jessica on more podcasts, YouTube, social media. I feel like the bill, that is absolutely, I support, OTs definitely advocating for bills that are being written, patients to have more access to services, for them to understand they have access to both physical therapists and occupational therapists during their perinatal journey. Absolutely spread the word on that. However, for the public to even understand why that bill is important, that to me is the next stage, right? A conversation like this for the public to understand that, whoa, there's a therapist in Pennsylvania, Jessica Hammond, that offers her services while I'm in the hospital. That to me should be spread all over that state, right? And all over any state where there's one or two hospitals offering therapy services to these populations, right? So yes, we need the research. Yes, we need the bills. Yes, we need, laws to kind of support really more services for this population, but we also just need the communication and education at the public level, right? They need to see us having conversations with them, not about them, right?
Yes. Excellent point. Thank you, ladies. Thank you so much. I'm just going to check the comments to see if we've got, Jerry, you're awesome. Oh, we've got Sabina. Fantastic. She's going to spread the word. That's what we're asking. That's what we want to hear. So thank you. And I hope that if you weren't able to join us live, you can watch the replay, put it in the comments. If you want information on how to take action, put it in the comments. We'll get back to you. Hope to see you at AOTA. And we're speaking again on Thursday, 3/21 at 10 o'clock in Orlando, Florida. So more to come.
Awesome. Thanks for having us.
Take care.
Thanks for having us. See ya.